And our main item of business today is an introduction of medication-assisted treatment MET standards. And we've got a number of excellent speakers as ever. And I understand our first speakers are to be Dr. Duncan Mccormack, Public Health Scotland, who's chair of MET Standards Subgroup on the Drug Death Task Force, and Tracy Klusker, the clinical lead on MET Standards. So can I pass over to you, please, Duncan? Thank you very much indeed.
Thank you. I'll just see if I can share my screen again. So, well, thanks for inviting me. I'm Duncan Mccormack, and I started working at Public Health Scotland just 3 weeks ago. So when I started this work, I still feel I'm NHS Lothian, really, but I'm gradually becoming a Public Health Scotland person. So the medication-assisted treatment standards, the definitions there, I'm not going to read it all out, but these are the reason the task force set up this subgroup is because there's good evidence that being on treatment is protective of people's health, and also that there should be easy access to that treatment, no barriers, there should be choice involved in that treatment, and there should be good quality care, like any other service, really. So this is the reason for the subgroup being. So what we have been doing as a subgroup, our work, basically we have defined 10 standards of care. We've helped people to implement them, and we're still doing that. We're helping people measure progress so they can work out how well they're doing at implementing the standards, and also feed that learning into the wider public health approach. So I'll just go through quickly each one of these 4 steps, but that is our overall strategy. Define the standards, help people implement them, help them measure the progress, and then feed all that learning into a wider approach. So the summary of the MAT standards are here. There's 10. The first 5 are really about service and delivery, quite specific things. Start easy access to medication-assisted treatment without any barriers, choice on what medication and dose, proactive support for high risk, it's anticipatory care. This is something which is standard in many other areas of practice, clinical practice, harm reduction and treatment for as long as needed. So these are the 5 which are service orientated. The other 5, 6 to 10, are more about system change. So a system which is trauma informed, psychologically informed, primary care, advocacy. These are standards which require quite a lot of different partners to work together to deliver something which is going to matter. The first 5 is really something which is more within the gift of services and teams locally and within AGPs and so on. So I'm not going to go into more detail on that. I think a lot of you will be familiar with these standards anyway. There's been a consultation which was launched in November last year, which is still ongoing and will finish at the end of February. The report on that, the feedback on the consultation, will be published in March, towards the end of March, and the final standards will be published sometime in May. So that's that. The next major bit of work for us is helping people implement them. So how have we been going about doing that? Well, the approach we've taken is a quality improvement approach and the diffusion of innovation approach. I'm going to briefly explain what that's all about. Lots of you will be familiar anyway, but it's quite a useful way of looking at things. So this graph shows here the whole population. 2.5% of us are innovators, 13.5% early adopters. The early and late majority is where most of us sit, and then at the end there's what they call in the literature laggards. It's really more conservative. So it starts off with a more innovative group, maybe higher risk-taking or less risk-averse, more creative, maybe more visionary. And as you go through, it's maybe looking at pragmatic people, the early majority, maybe conservative people who will come along with things, it's the late majority, and it's really skeptics, which form the last bit. All of these groups of people have a very important role in any innovation, either developing it or stopping it. So, because of course not all innovations are good. And I think we all can have a look at it and think where we are on that in our general lives, but also in this particular area of work. I'd say I'm a bit of a laggard in terms of handheld devices for electronic stuff, but I would say I was more towards the left, early adopter and early majority for some of these sort of public health things. So the key thing about this is that for it to work, you have to start small, which is why you can see on the left, the innovators, it's a small percentage. You have to start small, but you have to think big. You have to think about the innovation diffusing across the whole of the population of service providers in this case. And you also need to act fast. If you're too slow, then you lose the momentum. And the really important thing is for diffusion of innovation, you have to share the learning all the way through. Now, the other key thing is that this red arrow here, at about 16% of the population, in this case, population of providers or services or ADPs or institutions, when you reach a certain critical mass, you reach a tipping point. And that's when you move from the innovation being a scarce innovation to a pretty much normal innovation. And that's when you can start having it really diffuses across the population, and you have more sustainability. So how are we doing, what are we doing to make that happen? Well, at the minute, we're working with teams across Scotland to do small quality improvement, test to change projects, and also some larger ones. Tracy's going to talk about that a bit later. And that is really helping to move along with the innovators and the early adopters to get that critical mass built up. But what we plan to do soon, and with the support of the Scottish Government, is rapidly scale up this quality improvement work. And I think that rapid scale up is going to be moving not from projects which are linked just to single standards, but maybe working with a whole health board or a whole ADP to say, we're going to work with you to implement all 5 of the first standards in a package over the next year. We're going to help you measure them, and we're going to make sure that all the learning from that is disseminated nationally. And the aim is that the expectation is that that sort of surge, that scale up, will push us past the tipping point, so that we move into this area of the graph and start really having the innovation going across the whole of Scotland, so you can actually have nationwide implementation. So there's clearly a big issue with that, in that in order to do that scale up, there needs to be more resources. And actually, we're in a fortunate position where the government has committed more resources. So I think this red arrow is where we're hopefully going to get to quite quickly with the extra push. So the next part of our work is really about measuring progress. People get a bit worried about this because of quality assurance, maybe top-down sort of indicators and that kind of thing. What the MAT program team is doing is we're looking at measuring progress with local teams, working with them to measure the processes. So does the team have a functional pathway for rapid access to OST? That's a really good measure of progress. If you haven't got one of those, you're not making very good progress. The other really important part of local progress is, have the changes in services in order to reach the standards, have they made a difference to patients and to patients' families? So experiential measurements is really important. And there will be some numbers as well. For example, how long does it take somebody when they first present to a service to get onto a script for what they need? It might be Bifidal, it might be methadone. So it's really about local collaboration to assess progress. But the learning from that will be fed into the national public health approach. So it'll be fed into national quality assurance, national indicators, and also national implementation. So that's the approach we're taking. And I'm going to go on to Tracy in a minute too, because that's she can tell us about the work. So that's her up at the top there, taking little steps up the ladder in order to get to where we want to be. It's about doing what we can do for now in order to get to somewhere where we want to be. So that's it for me. I'm going to move now for Tracy.
Thank you, Duncan. Hi, my name is Tracy Klusk, and I'm currently working with the Scottish Drug Deaths Task Force. I've been on secondment full-time since October, and I feel we have actually, within the MAT subgroup, achieved quite a lot of progress in terms of the chart and the early laggards and getting people on board. So over the last 10 months, I think since March, we've started our very first Q quality improvement projects, starting off in NHS Lothian and NHS Borders, and that was really around standard 1 to 5, and despite COVID, around getting people quick access into treatment, mainly OST, and offering that wraparound support in terms of needle exchange, naloxone, as well as anticipated care. So one of the projects was in Edinburgh. It was someone going out on foot to look for people during COVID to try and get people who were most vulnerable into treatment quickly. So 5 of the projects have concluded, and they're offering that as their day-to-day business now in terms of rapid access. So some areas are very alive in terms of the MAT standards, and they're working towards, you know, now moving on to the wider standard 6 to 10. We are currently working, this is an ADP tracker, so this only resembles the areas that we're working in. So Saket, I think, will come on later and talk about, so there's areas doing some other work that we've not captured. So this is mainly based on quality improvement work that the task force has been involved in. And as you can see, that it's quite a difficult slide to read, but you can see we've done engagement visits with all ADP areas. We've been out, done consultation with teams on what the MAT standards are and what the barriers would be for them. And we have went out to Scottish families, we've went out to people with lived experience. So we've tried to consult wide across all the ADP areas. And the ones that are in blue, you'll see that's the projects that have been completed and consolidated, and people are working towards that. But you can see we've got 17 live projects just now that are all using QI methodology to work towards starting, for instance, in some areas, small test of change in one local area to embed that, learn from it. We're using plan, do, study, act cycles so people can report in real time. We're trying to gather across the areas consistent data points, because everyone, as Duncan says, will collect local data so we can feed that into the national indicators at a later point. Some of the projects we're doing have been around same day access to OST, some around drop-in availability in some areas. We've tried to link work up, so we're working with North Ayrshire on a project just now, but because you can see the borders are really have embedded this in practice, we were able to get the borders team to meet virtually with the NHS, the team out in Ayrshire, to share standard operating procedures, to share experience, and to really build confidence in the teams and tease out what some of the fears are around different ways of working. We are starting to move on, and we'll continue to support local projects, and we are getting requests every week for new projects to come on board. We also have some projects that are across the country around peer naloxone, and we're linking that to the STF work in the peer naloxone projects they've got. So again, linking that work up together to diffuse innovation across the country. We also we're now working with 5 areas on, so all these projects, I have to say, so far that we've been involved in have not been funded at all. This is areas adapting what they do, working, you know, sharing practice. So there's actually been no funding investment so far anywhere on this tracker, but we are now starting to look at projects that we want to invest in. We're working on 5 projects, and that is looking at these standards 6 to 10 to start getting wider learning around what does a trauma-informed service look like. So we're hoping to fund some projects and some around standard 6. What does how do we psychologically train our staff? What would that look like? How, you know, what's that investment? What's the business case if we want to meet standards 6 to 10? And we're also working with an advocacy project around what rights-based treatment looks like and how we can look at systems and culture changes. So we're working with slightly bigger projects now, and as Duncan says, we're hoping to go and identify places. This would be the next, the larger scale up would be to identify places and work with them using the measurement tools that we are creating to track data to feed into the wider system. And also we want to be working with areas to look at a service specification, develop that with them jointly in order to deliver the standards and support people in terms of standard operating procedures, use the expertise we have in the task force around clinical governance, and share that and feed that all back into the wider picture. So whilst the MAT standards are out for consultation and that's complete and it will be published in May, we are working very, very closely and intensely with a number of ADP areas. And another subgroup that's worth mentioning is we are doing some work also around benzodiazepines and what clinical guidance and clinical governance to give best practice for that would look like, feeding into the research. Have Katrina and Joe Schofield on that group as well, and maybe perhaps looking at some QI work around how we implement work around benzodiazepine prescribing and trauma care for people who are using benzodiazepines. So if you go back to the ladder, we are making steps, and I think when I looked at that ladder earlier this morning, I thought if you also, you know, I always like to see it from a person's perspective and their family. In some ways we want those that jump not to be so high for people to get on that ladder to treatment. We want these services to work in a way that they can also get on that ladder to treatment and their best outcomes going forward through the delivery of the MAT standards. So that's me, happy to take questions.
Okay, thank you very much indeed, Duncan, and thank you, Tracy. We'll take questions, Q&A at the end of this, because we've got two further speakers, and our next speaker is Colin Hutcheon, Chair of the Scottish Families Affected by Alcohol and Drugs. So over to you, Colin. Thank you.
Thanks, John. Yeah, just to introduce myself, as you say, I'm the chair of Scottish Families, but I'm also the family representative on the task force, drug deaths task force. And really today, I'm not here to talk about myself or express my personal opinions. I'm here representing families, and I'm going to do my best to try to represent their views on this particular area of work and this development. And well, from the outset, I would say, to make it clear, families are very supportive of this development, the new MAT standards. And the reason for that is it responds to and deals with issues that they have been raising for a long time, really important issues. And I'll explain a little bit more of what I mean by that. But just to put some background into this, when I joined the task force, fairly quickly thereafter, we set up a family reference group so that I could go back, because I was only family representative on the task force. I needed to be able to talk to a wider source of views. And we set up a family reference group which represents families from the borders right up to the Highlands, which we're really pleased about. And they submitted very early on, in October I think it was 2019, what they regarded as their priorities for action from the task force. What were the things that really mattered most to them in their experience? And I'll just summarise them very quickly. There's 5 immediate actions, but it's very relevant to what we're talking about today. And the first one was about what they described as an end to the postcode lottery in treatment and care services, and to ensure equality of access. So that, number one, it's really important because people were getting very different experiences depending on where they lived. The second one was about wanted some immediate, if possible, why not aim high, immediate removal of all barriers to treatment and care for all services. And that's about the fact that a lot of families' experience was when they were concerned about their loved one's situation and they were seeking help and wanted to engage with treatment services, they were being confronted with sometimes ridiculous waiting times, up to 6 months if they wanted to get on a prescription, medication-assisted treatment. And also there was what felt like a lot of barriers were being put up in the way, and sometimes there were unrealistic hurdles that people were having to cross. And if they failed to do that and failed to comply with a whole list of conditions, then it felt like they were punished. And there was a punitive response from services. It sounds maybe difficult to believe, but it is very common. And they knew that this was not right. It should not be happening and it had to change, but they didn't really know how to make it change. And when the MAT standards came along and I first got sight of them, although I'm not actually on their subgroup, I'm on another subgroup, multiple complex needs, I was really pleasantly surprised, quite excited actually when I saw what was on the list, because it dealt directly with a lot of these very issues that families were frustrated about, and particularly about equality of access and no barriers to treatment. Our other requests, just to mention this at the moment, were the third one was about a presumption of family involvement. And the reason that we were looking for that, and I'll maybe come back to that later, is that it's really just fundamentally about being treated with respect and in the way that other patients, clients would expect to be treated. And that wasn't often their experience. In fact, sometimes their experience was quite the opposite. And it just didn't seem right, and it isn't right. Their loved ones were not treated with the same kind of respect that others were, and neither were they by association. So we wanted that to change. The other two things have actually, I'm happy to say, have been taken forward quite quickly. That was about wider distribution and use of naloxone, and that definitely has been developing very quickly. And a national anti-stigma programme, which is developing, has progressed quite a bit as well. And because stigma is a huge issue, but I don't have time to go into that today. That's for another day, I think. So, in summary of that part, I've got a few more things to say, but there is a close alignment between what were identified as the family's priorities for change and things that they thought would save lives in their experience, and the draft MAT standards. So that's why we were really pleased to see them and encouraged. And we invited Tracy to come along and speak to our group, and they really appreciated that, and it was a very useful exercise. But we have one of two caveats that I would mention just now, because we have submitted a response as part of the consultation on the MAT standards from the Families Reference Group. So there's a number of issues which I would mention, which I hope will actually be taken on board as we go along. But just important points that within the MAT standards as they exist at the moment, there is no explicit mention of families and about family inclusion. And we think that really should be in there somewhere, so that it is much more explicit rather than just something that we assume would happen. Because actually the quality principles have been around for a long time, and they mention that services should be family inclusive as part of their practice. And that rarely seemed to happen for some reason. And in the government strategy, rights, respect, recovery, it also mentions that family members will have access to support in their own right, and where appropriate, be included in their loved ones' treatment and support. So we're really just asking for things which already exist to be implemented. There's nothing new. Sorry, I thought someone was interrupting there. So that's one of the requests that we would make going forward, that there's a clear reference to families. Another thing which probably concerns us a wee bit is about the lack of accountability, but there may be plans for that going forward, and I certainly hope so. I know there is at the moment during this period of time, but in the past, I say people's experience has been that it doesn't seem like drug treatment services have been accountable in any particular way, which doesn't make it particularly empowering for family members when they don't really think there's any redress. So I think that's an important point that we would like to see tackled as well. Another one is it's about resourcing, I suppose. But the point, strangely enough, we do understand that additional resources are needed. There's no question about that, and people could argue that the services have been underfunded for quite a long time. And this is a big development, and it's to be national, so it does require additional resources, and we're pleased to see the additional resources that have been made available recently. But we also feel strongly that there's some of these changes can take place without any additional resources, because it's about a cultural change, and we have seen it happen in some areas of the country already. So that's just about people being prepared. I suppose it refers back to what Duncan was demonstrating there, that some people like to wait until they have to do something rather than, well, that sounds like a good idea, let's just do it. But there are some of these things which are really just about people's rights, respect, how you treat people, that should change now. We don't have to wait for money for that. So we really are anticipating that as this rolls out and more people get to hear about it, that we will see a change, and some of the bad experiences in the past will not be repeated. And finally, we have just a little bit of concern. It was just as a reference group that the focus is very much on people who use opioids and the treatment for them. And we're obviously, families are involved with people who have problems with all sorts of substances. And we just don't want them to be forgotten about. I'm not suggesting that's the intention, but It's just a kind of reminder there that they need to be treated as well, because some of them are just as at risk of dying prematurely. And my final words, I would just say, is just to remind people that our view is very much, sorry, I lost my place here. Yeah, so sorry. Some quotes actually from family members, which I would just like to share with you. Talking about the draft MAT standards after they'd had that session with Tracy. And some of them have described it as a breath of fresh air. And it's not very often they say that, I can assure you. Someone said it was a glimmer of hope, which is very important. And that this will make a big difference and save lives. That's the most important thing. So we don't underestimate the challenge facing anyone who's involved in this to successfully implement it nationally, which is really important. And we are keen as Scottish families to do our part to support the Scottish Government and local partners as much as we can to make this process a success. Thank you.
Thanks very much indeed, Colin. In one respect, disappointing to hear that we even have to mention that people should be treated with respect and have their rights respected, but I'm sure we'll return to that with the Q&A. Our next speaker in the final of the four, last but not least, is Dr. Saket Priyadarshi, and Saket's going to is the Associate Medical Director at Glasgow Alcohol and Drug Recovery Services. So Saket, many thanks.
Yeah, thank you, Chair. Good morning, everybody. I hope you can see my first slide. Believe it or not, we're 11 months into the pandemic, and this is my first Zoom presentation. I have attended many meetings, but first time I've presented, so I hope I'm getting this right. Okay, I'll proceed. So,
it's on screen, Saket. Sorry, your opening slide is on screen there. Thank you.
Okay, thank you very much. So I think I've been asked to present a perspective from clinical services around the implementation and delivery of MAT standards and some of the potential benefits we see in this and some of the challenges. And I also want to take the opportunity to share some of the work we're doing in Glasgow that hasn't quite made it onto Tracy's map there, but we do consider ourselves in the early part of the graph that Duncan showed earlier. And I hope to demonstrate some of that as we go on. But I guess just to echo Colin's point that I think this is really widely welcome in the treatment services and clinical community in Scotland. And we do see with the new financial framework that was announced recently some glimmer of hope that we'll be able to implement this to the capacity and standard required in Scotland. But I want to start off with a bit of a confession, which I think I'm representing partly my own views, but I certainly know this from my colleagues across Scotland. Some of us felt a bit like Phil here at the start of the MAT standards work. And by that I mean middle-aged men who've been working in this service for a long time, feeling seething with anger really at watching what we thought was the wheel being reinvented yet again, because we strongly believe that actually the evidence base for medication-assisted treatment and how to deliver it has existed for a long time, and we were very worried that we were about to have another national group that would present what was already out there in terms of standards. But I can say that with Duncan's leadership and Tracy's efforts and Eleanor and others, I think what we've reached is a set of standards that will help us deliver medication-assisted treatment to a high capacity and high standards across Scotland, in keeping with the evidence base that exists and in keeping with the UK guidelines on clinical management. Now, I think it's been very positively well received that the standards accept and have built on the current evidence base and the guidelines. and are looking to reduce the geographical variations and improve access and quality across Scotland. And it's really absolutely well understood across Scotland that this is well needed, much needed. So in my own health board and in Glasgow City, for example, we have more than 50% of people who use drugs not in treatment. Our coverage is probably just between 45 and 50% at the moment. And if you consider that the national coverage is less than 40% possibly, it suggests that in some localities, in some areas, there must be very low coverage, close to 25, 30%, which is very worrying. And we know that people who are not in treatment, who are outside treatment services, are at the highest risk of drug-related harms, including drug-related death. And we also know that if we leave them outside treatment, then they are more likely to develop worsening and worsening drug problems. And that's why some of the work that we've been doing in Glasgow is really about engaging and finding people out of treatment and engaging them into services. So you'll see here on the left, we've got an outreach team. In the middle, we are taking our services out to the hotels and hostels rather than expecting people to come to us. And we're linking very assertively with our acute colleagues in, for example, emergency departments, where we identify people with repeat attendances related to problem drug use. And we follow them up assertively as well. And all of this work, just even during the COVID time, has led to really positive engagement. So for example, for our Glasgow City Centre cohort, we have increased treatment coverage to over 100 new patients coming into treatment despite the COVID restrictions. In order to deliver this work, though, you need to have staff who are able to do this work. So there's capacity required, and then there's attitudes and values and the right type of approach for this population in particular. You need the partnerships with third sector providers, with your housing and criminal justice and police colleagues, and with acute and primary care colleagues in order to have a system where you can genuinely reach the people who aren't known to services at any time. But when people come into services, there's absolutely no point in accepting referrals and leaving people on long waiting lists. So we've been looking at reducing our waiting times to treatment in Glasgow for a long period of time. And I'm sharing with you a snapshot of an audit we did in the spring of last year, where I've described the teams as our 4 teams as A, B, C, and D. And the 2 lines to look at are median weekdays for starts and percentage of ORT start within 1 day. And you'll see that in most people presenting for medication-assisted treatment, and I'm using medication-assisted treatment, ORT, OST, and OAT, opiate agonist treatment, interchangeably. I'm really sorry about that, but we probably need to agree nationally that we're just going to stick to medication-assisted treatment as soon as the standards are accepted. So you'll see that although most people were initiated into treatment within 8 days, which is very positive, there was quite a significant variation in our teams, which all work to the same specification with regards to offering same-day starts. So 2 of our teams were able to start 50% of the new patients on the same day, and one of our team none. So we took the learning from that and have developed a standard operating procedure to support our teams to be able to offer medication-assisted treatment, new initiation and restart of opiate substitute treatment, as we call it now, as soon as possible, and to the same standards across all 4 teams. And this was very much in response to drug-related deaths and the drug death task force work that aware of. So we want to outreach people. We want to offer access to treatment as soon as possible. But we do know that one of the problems we have with regards to medication-assisted treatment is actually the lack of options. We don't have a shelf full of options for different options for people, certainly not evidence-based options. And therefore, we've been trying in Glasgow to increase the treatment options for our service users. So you'll have heard that we've been implementing heroin-assisted treatment for the last 14 months now. That's really for a very small number of people at the most severe edge of problem drug use. But for others, what we've been doing is we've been implementing Buvidal. Buvidal is a depot buprenorphine preparation injected into the abdomen. And what we're finding is that actually Buvidal is very attractive to new patients and to people who have been out of treatment and wish to come back into treatment. So again, this is a very short snapshot of a experience in the South Glasgow community team, where when we looked at 32 new MAT starts in June and July last year, we found that 8 were new patients presenting for the first time, and 7 of the new patients chose Buvidal. And actually, of those returning to treatment, 1/3 of them chose Buvidal as well. So we think that by offering new treatment options, we will be able to attract, we will be more likely to attract people who are currently out of treatment, not known to treatment services, but also bring back people who perhaps hadn't had positive experience of previous treatment options. You'll know that the benefit or the attraction of Buvidal is that it becomes a once weekly and then a once a monthly injection, which means that people don't have to go to pharmacies on a daily basis, and there isn't the same stigma of supervised dosing in the initiation period. Once in treatment, we want to retain people in treatment for as long as they need it. And one of the problems we clinicians find is a reluctance amongst service users to go to optimal dosing for opiate agonist treatment in this case. So we've been really trying to understand some of the barriers relating to that, because we know that optimal dosing is associated with the best outcomes. And we've been working with Scottish Drug Forum, and that work is in progress and will report in due course. And it's about developing partnership approach with service users so that we can have an evidence-based and well-informed conversation about how to optimize their treatment, as well as individualizing it and making it as person-centered as possible. And of course, we can't just give lip service to partnership. We have to support our service users' rights within our services. And we've invested in an advocacy service for our service users. This is a photograph of a session where our managers are being briefed on the advocacy service. And this is part of this culture change and approach change that is required that Colin was hinting at and others have talked about earlier. But I want to move on now to some of the real key day-to-day practical challenges that we face in terms of improving outcomes in relation to medication-assisted treatment. And this is a police photograph of a pill press found in the west of Scotland. And you can see the bucket on the left and the amount of blue street benzodiazepines that are produced there. That's atizolam. And you heard in your last meeting, Chair, I think, that drugs have never been so easily available and so cheap. And that's particularly true for atizolam. And atizolam has really is the single drug that's driven our drug-related death figures in Glasgow to the extent that we are at the moment. And it's a drug that erodes a lot of the benefits of medication-assisted treatment. And I was really pleased that we're working with Tracy and others around national approach to benzodiazepines. And we've developed our own benzodiazepine prescribing guidelines to try and manage this. But I have to say to you that prescribing for benzodiazepines is not something that's approached with consensus amongst all clinicians, and the evidence base for outcomes isn't as well developed. So we need to think about a prescribing and psychosocial approach, but also we need to think about how we can reduce the availability of street benzodiazepines, because otherwise I think getting the reducing drug-related deaths and getting the benefits of medication-assisted treatment are going to be challenging. Finally, just a couple of slides to end. COVID has shone a light on a whole range of issues within society and inequality in general. But one of the major impacts has been the digital exclusion of our service users and potential service users in an era in which we're going to remote working, and we've been increasingly trying to use platforms such as NHS Near Me. Many of our service users don't even have Wi-Fi or mobile data to engage with this, and that makes engagement very difficult for them and for our staff in terms of outreach and in terms of regular contact. This beautiful room is the counselling room in the new Simon Community Access Hub in the Glasgow City Centre aimed at engaging homeless people in the city centre. It's, if any of you haven't visited and you get a chance to visit this facility, please do so. Simon Community have led the way in a psychologically informed, trauma-informed environment where you can see service providers, the staff energized and really positive about the work they do, and you can see the effect of this environment on people who are coming to use the services. I haven't seen a treatment room anything like this quality in any of our drug treatment services, certainly not in Greater Glasgow and Clyde, and I have been to a few others across Scotland, not those provided by the NHS or the councils or the HSCP. And this made me really reflect on the work we need to do within our services, not just to make them trauma-informed and psychologically informed, but also the investment really required. And as part of that investment really needs to be in our workforce as well. Our workforce is carrying very large caseloads of complex people who require more time than our staff are often able to offer. Our staff experience the vicarious trauma of losing their service users to drug-related deaths as well. And they also suffer from feeling a sense of blame from outcomes such as drug-related death situations in Scotland. So I think the morale, the resources open to, and the number of staff needs to improve and increase in order to for us to improve our outcomes related to medication-assisted treatment. And there's a huge challenge around recruitment and retention of staff into alcohol and drug services. And I think the MAT standards work needs to run in parallel with the workforce development work that needs to address these issues urgently nationally. This image also depicts the stigma that many of our service users feel about coming into treatment services. And I think there's a lot that could be done in political discourse to improve this and to address the stigma addressed by service users, but also the stigma associated with our treatment services. Finally, just want to end on a positive note. I'm absolutely confident that if the MAT standards are implemented to the aspirations that Duncan, Tracy and others describe, then they will really produce in due course really positive outcomes for us. But we need to also measure the steps in the ladder on the way to the outcomes, and we need to understand what those outcomes are. And I'm working with colleagues in contributing to that outcome measurement. But it's a very important part of the project, I think, and it's something that we certainly in Glasgow are thinking a lot about. I've probably gone over my time, but I hope that was useful and happy to be part of the discussion now.
Saket, thank you very much indeed for that and for telling us about a lot of the positive work's going on there. There's clearly some recurring themes and about respect and stigma and the digital exclusion.